Dougie Boyle is a Professor of Clinical Data Analytics at the University of Melbourne, Department of General Practice and Primary Care. He leads a professional and academic team specialising in enterprise-scale data acquisition, clinical decision support, and common data model implementation. At a national level, Dougie leads the Australian Health Research Alliance Transformational Data Collaboration that is leading work on data quality, data mapping, and common data models to ensure better and easier access to health data for research. Dougie is the technical lead for the Melbourne Academic Centre for Health, the MACH node, of the HeSANDA program. He will present to us today about unlocking data for secondary research and the impacts on future research and health outcomes. Thanks, Dougie.
Okay. Thank you very much. Okay. So look, I'm delighted to be here to chat to you today about this subject. I'm an advocate of where we can take things into the future, so great to be here. As Katie said, I run a technology unit, so we're very much at the forefront of trying to actually do things rather than, I suppose, talk about the theory of it. Just looking at the theory, a lot of the time, traditional research, you end up with papers being published, but certainly what we try to do is work around the concept of learning health systems, where what we're actually trying to do is close the gap. It's not just about having journals output, but it's actually taking things further and being able to drive change and real world outcomes. So this is the sort of model we have, where it's things like data to knowledge, and using that knowledge then to drive changes in practice, and then use changes in practice and that data then to further drive change. The background, so in our focus about trying to take things forward, at our Department of General Practice, we've got a data set that we work with general practices with, and that's got about 5 million patients in it. That's been used now. We've had about 100 different applications for the use of this data for research, and it's a direct research collaboration with practices and an independent data governance committee. But one of the key things here is just what we've been able to do once we've started to gain access to a lot of data. So first of all, what we've seen is that regardless of your data sets, there are real world practical data issues out there, in particular things like primary care. You've not got clinical coders like you do in hospitals. And what we see is there's a lot of free text in notes and things like that. So if you rely on codes, then you would be missing out on nearly 25% of people with chronic kidney disease, as an example. And of course, that's a huge one in terms of patient outcomes and hospitalisation and costs. So it's a really important thing to understand. And looking into the future, of course, where we've got things like AI or other mechanisms, it becomes easier to interpret and understand things like that text. And I think that's really important. Our ability to drive changes is increasing through some of the technologies that are happening. We've developed a clinical decision support tool that runs in GP surgeries called Future Health Today. So this is an example of that translation. So this is about taking knowledge in the data and thinking, okay, so we actually know quite a lot now about how to interpret the data. So can we do something that can allow us to change the way general practice works? So this tool sits within a GP surgery, and it can give you things like pop-ups in the bottom right-hand corner here, driven very much around the data that's held in the GP's electronic medical record for that patient. And currently the system works across a number of different areas. So here you can see we've got different algorithms and risk profiles around cardiovascular disease or cancer or diabetes. So this is really exciting for us to be able to actually put real world things in based on secondary uses of data, and actually help drive potentially lowering things like patients transitioning to type 2 diabetes or capturing people earlier in the process before disease progresses. So it's really, really important. So this is just showing the fact that you can look at lists of patients for different that are in different cohorts that have different diseases, so that the GP can look at those or delve down into the medical record beyond and why a patient has been recommended as having different problems. And the system has got an ability to look at scheduling things, because you can't deal with everyone's problem every day in general practice. This is about real world stuff and how we can actually engage with patients over the longer term. That's just one aspect. So what we've looked at there is just one piece of data, one type of data, general practice. Now, the challenge comes when we're really wanting to look across the continuum of care, and how do you do that? And one thing that can help in that is trying to standardize how people collect data. And we've been having a look at the largest model in the world, the OMOC Common Data Model, that has had around about 1 billion patient records converted into this for the purposes of research. So the idea here is that instead of having lots of different database formats, you pick one and you pick common vocabularies, and it effectively acts as a converter, allowing you to sort of standardize what you're doing in research. So this is probably what we have right now, are pockets of data, and we've got lots of silos in Australia. These are gradually being broken down, but we have lots of challenges. So what happens is people apply for access to data for data sets like that. The idea with the common data model is you can potentially run the same query across different data sets. So immediately you might not need a data release, you might just be able to run a query on top of someone's model. Where it becomes really useful is though when you combine it. So this is where I see us being in the future. So if we think about national integration, we could be taking things like GP computer records and disease registries along with national administrative data. So this is showing that we potentially could get that combined. People will understand that there's lots of privacy issues that people have in combining data, but the advantage here is when you bring it into a common data model, someone can submit the research question to the model and get the results back rather than needing the data to be released. So that's why this sort of thing is a real game changer for the future. Having a common model means you can access the world community in terms of the tools that have been developed for running research, as well as the ability to run data quality audits over this in standard ways. This is a dashboard. This is showing our same patron database converted to this model. And this is a tool called Atlas. So you can see in this tool, it even allows us to do patient level prediction. So imagine being able to go into a single tool which can do whole things right from the start of a study design, looking at cohorts and pathways, right through to very advanced patient prediction to try and put things into the real world. So I've got just a quick example here called Legend that's been undertaken through the international community using this model. And if you look at clinical trials looking at hypertension where they've compared drug use, this is what that looks like around the world. There's been a number of trials to try and look at guidelines for hypertension. But by bringing the data together from lots of different groups around the world and doing this electronically, you can see the vast difference in real world analysis that's been able to happen to look at first, second, third line choices in hypertension and how they work. And the tools are able to give all sorts of beautiful outputs showing first level, third line choices in different countries here. And this is obviously in the public domain and published, and there were 4.9 million patients in that combined study. And the clever thing is here we've been able to actually run that on our data set. So we've been able to run the same thing by pressing a button. So that's an idea of the sort of power. I want to finish off. You can see some of the potential there by opening up that data to the secondary uses. But where I think the future really lies now is with disruptive technologies. I think generative AI is really changing what is possible across a whole range of different areas. So certainly it's going to be interesting to see how this goes into the future.